So I was given the title of Innovative Trials from the last 2 years, and it's a pleasure to be asked to talk to this. I'm going to disclose that I've picked trials that I know something about and that I'm involved in. I'm the chief investigator for Dante. I'm Sheffield PI for various other studies that I'm going to mention. I also emailed around nationally and said, if you want me to talk about your trials, send me some slides. So a bit of it was what got sent through as well. But other trials are available. Okay. Now, we had a really great overview at the beginning from Paulum, and I had to go out for some of it, so I'm not sure if we talked about the background of systemic therapy and melanoma, but we have come so far. I haven't been treating patients quite as long as the left-hand side of this, but for at least half of it, and I think some of my colleagues have been involved throughout. And we started off, we really didn't have very good treatment options. We gave dacarbazine, which worked for some people, but many it didn't work for. We did lots of trials with immunotherapies such as interleukin-2 and interferon, and then really everything began to change in the early part of the century when we were all doing these trials with BRAF inhibitors and with ipilimumab, the CTLA-4 inhibitor, and we began to see that patients were doing really well. And I know that some of you have benefited from that. And then, of course, the PD-1 inhibitors came in as well. So we now have treatment options. We still don't have enough treatment options. So if you had a table like this for breast cancer, then it would go on and on and on, possibly onto subsequent slides. We still do not have enough treatment options, especially for patients that don't have a BRAF mutation in their tumour. It's fair to say that a lot of what we do is immunotherapy. And the reason that a lot of it is immunotherapy is that immunotherapy does work in patients with melanoma. So if you can look at this, we've got, I'm not sure. At the top, we've got the chest with pulmonary metastases, so the blobs in the lungs are not supposed to be there. At the bottom, we've got the brain, again, with the white areas that aren't meant to be there. And you can see this patient on immunotherapy responded over time. So this was over a period of 6 months, but has continued to respond for the subsequent 10 years. So to be honest, the more I think about what we've achieved in melanoma, the more I realise how many unanswered questions we've got, and I'm not going to try and cover them all. I've left things such as ctDNA and how to serve those who don't have as many options, such as those with brain metastases and the oncolytic viruses, to my subsequent speakers. I'm going to touch on the areas in red for my particular talk. But really, the talk could have looked very different depending on who had sent the slides through. This is just a very quick overview to say that if you go on the NCRI portfolio and you look at the portfolio maps, which I have to say are not completely up to date, then you'll see that there are many, many different trials out there, from surgery at the top down to observation at the bottom. So there are lots of trials ongoing and there's lots of trials in setup, and I'm sure that the melanoma-focused trial finder will be more up to date than that. I'll just keep clicking. Right. So I'm just going to start off. This was actually mentioned in the first talk about the microbiome. So these are a couple of slides from Pippa Corrie to say that we're increasingly interested in not just the drugs that we give to the patient, but how the body reacts to the drugs that we give. There's lots of talk about the microbiome, so how the bacteria that live in our mouth and gut actually affect the cancer treatment that we give. And that can be affecting either the response to cancer treatment or the toxicity and side effects that patients see. So the trial that's ongoing at the moment is the MITRE study, which is open at those centres on the map, which, of course, when I look at it, I think, well, you don't want to be in the north, do you? We need to redress that slightly. But this is a trial looking at patients with several different tumour types, including melanoma, including those that have had treatment for advanced disease and those that have had treatment after operation. And we're collecting information, a mouth swab to look for bacteria, stool samples, which I know is not the nicest thing to talk about. I think there's a lot of hesitancy about having these conversations with patients, but 4 stool samples, extra blood samples, and we're going to collect lots of information, especially about things like antibiotic use, so that we can work out how patients do compared to what's going on in their gut. Then I'm obviously going to give a plug to a trial that I'm chief investigator on, which is the Dante study. And this is looking at actually how long should we be giving treatments for. So historically, when we gave ipilimumab, we gave 4 cycles, so 12 weeks of treatment. Then we moved to the PD-1 treatments, and we gave them until progression. Then we started to give them for 2 years. But actually, can we give them for less time? And why would we want to give them for less time? Well, do we need to give as much? Can we improve quality of life by not giving them? Can we reduce side effects by not giving them? And can we save money by not giving them? So Dante is addressing that question. It's very hard, though, to take a treatment away. And so we've had much patient input into this particular study. But the main message is really that more isn't always better. Sometimes more is just more. So this is the way that Dante's set up, in that we register patients who are either just starting PD-1 treatment or who've been on it for less than a year. We register them to gain interest and to follow them up. And then at a year of treatment, if they haven't progressed on the treatment, then we either randomise them to carrying on the treatment as they would to normally, or to pausing the treatment with the potential of starting again if they ultimately progress. So as I said, there's a registration and a randomisation stage. You're not committing yourself from one to the other if you go into it. We have had patients that have changed their minds about wanting to take part, some because they didn't want to stop, some because they did. We monitor people the same way after randomisation. As I said, we can restart treatment if disease progresses. The only additional requirement, we don't want extra scans, but is quality of life questionnaires. This is running at 40 sites. I think there are 40 around the UK. So hopefully we've got good coverage from that point of view. We're on the Melanoma Focus Trial Finder. We've also got a lovely video of me and the research nurse, which you can access through the Trial Finder as well. So moving on to novel drugs. So I'm slightly intimidated that we have both Paul Nathan and Mark Middleton in the audience, and I'm going to talk about a drug that they have a lot of experience with. So tebentafusp is a different type of immunotherapy type drug. You need to have something called the HLA-A2 present in order for it to actually work, and that's present in about 50% of patients. The drug targets that side of things. It's something that we are looking at in melanoma itself, but the striking thing about it is the benefit that's been seen in patients with metastatic eye or ocular uveal melanoma. So this is small, but actually I want to for those of you that do like to read more around the subject, the New England Journal does these great summary pages of trials, which has got the relevant information on it. And this is the one for the trial with tebentafusp. It shows the mechanism of action. It tells you how many patients were in it, but it also shows what we're very interested in, which is the improvement in survival on that middle figure. So this is a drug that we are hopefully going to be able to give to all patients with metastatic uveal melanoma that are eligible soon. It's going through the NICE procedure. According to the NICE website, there'll be an outcome next month. The reason I mention it here is that we're looking at it in other indications. So this is the TEBI MRD trial of Mark Middleton's, where we're going to take patients who have different indications, so those that have finished their adjuvant treatment for cutaneous melanoma and those that have got high-risk uveal melanoma, so after surgery. We'll assess their HLA status and then we'll monitor them with ctDNA, which I'm going to leave to Becky to talk about next. And in those where we see a signal where it looks like the disease is becoming more active again, we'll then think about treatment with the tebentafusp. So that's being set up at many sites at the moment. Then I'm just going to move on to more intensive therapies. So many of you will have heard about things like TILS therapy and CAR-T therapy. I asked for some slides from my colleagues. They sent me hundreds of slides. I've tried to narrow it down to what I think are the important points. So really, it's about the fact that we are taking tumour from patients and taking out the white cells, the lymphocytes that are inside the tumour, and increasing the number of those so that we can then give those back to the patients, as well as taking the blood cells as well and increasing those numbers too, so that again we can give those to the patient. So this is how the patient journey overview is described. That first of all, you have your tumour tissue taken, then you're giving chemotherapy to reduce your immune system. Then you're given the tumour-infiltrating lymphocyte infusion, which is billions of these TILs, and then you're giving IL-2 after that in order to keep trying to make the treatment work. So that all looked very well, but my immediate question to the PIs was, well, how long do you need to be in hospital to do this? So hospital stay with these is typically 3 weeks. First of all, you have the chemo, then you have the TILS infusion, and you may have toxicity as well. You likely have toxicity as well. And then you stay in for your resolving toxicity. But why would we do it? Well, we do it because actually the results with it seem to be very good. So even in those that have had previous immunotherapy, we're talking about 36% response rates, of which about 5% are complete responses. In those with who haven't had previous immunotherapy, it seems to work even better, 60% response rates, 30% complete response. And the thing about these responses is that they seem to carry on, and in fact improve. Despite you having one treatment, the responses deepen. But there is significant toxicity, and also the potential worst case scenario of death due to treatment-related toxicity. Something we've always seen with the immunotherapies though. So these are a couple of trials with these types of treatments that are open at the moment. So Delta 1, the CI is Pipacori, and this is looking at 3 cohorts of patients, which you can see there. So those that have not responded to PD-1 treatment, those that have not been able to tolerate PD-1 immunotherapy, and those who didn't have a particularly good response to PD-1 immunotherapy, so had stable disease as their best response. And the pathway is just like we've talked about. You take the tumour, you then give the chemotherapy to suppress the immune system, you then give the TILs back, and then you give the interleukin doses following that as well. So this is open at the present time. And then also running, we have slightly different types of TILS therapy. So this one is one that's targeting neoantigens, so new things that we can see in the patient, new abnormalities. And this is being run by a company called Achilles, where again, we take blood and we give back the infusion to the patient. This is sold as being slightly less intensive than the previous, but time will tell us if that's the case. So Achilles has 2 main trials going on at the moment. The one that's relevant to patients with melanoma is that those with recurrent or metastatic melanoma can go into the Thetis trial, which is being run from the Marsden. Their slide actually said they got 3 sites, but looking on the clinical trial information, there are now 7 sites open. So that, again, is patients with cutaneous melanoma. We do need to think about how we treat patients with other types of melanoma with these treatments as well. And then just coming on to the final bit is looking at what we should be combining together. So this is not new. This is the Checkmate 67 study, which many of you will have heard presented multiple times. So this is taking ipilimumab that targets CTLA4 and nivolumab that targets PD-1, putting them together, and it was compared against nivolumab and ipilimumab on its own. And we could see very soon after the trial started that the response rates were much better with the combination treatment of nivolumab and ipilimumab, which we have now given to lots of patients. But what we could also see is that there was significantly more toxicity when you give the doublet treatment, so over 50% severe toxicity. However, I think we're all quite good at treating those now. We've got good pathways in place for treating them. My reason for putting it in here is that we keep looking at the data, keep checking that it still applies. So these are data from 6.5 years follow-up for the trial, which show that if you look at the overall survival on the right-hand side, those advantages still persist if you had the doublet treatment, which is the red line at the top. This is really encouraging to see, and I'm sure we'll keep seeing the trial papers coming through from that point of view. We also need to know about late-term toxicities with these types of treatments as well. So I'm just going to mention LAG-3, which some of you may know about as well. So ongoing trials with the LAG-3 molecule combined with nivolumab. Again, this is something that is probably going to come into standard of care, or we hope that it will come into standard of care. So this is another immunotherapy targeting drug, which we hope will have less toxicity than the nivolumab and ipilimumab combined together. And again, you can see progression-free survival there there looks to be a difference on that graph. We'll wait for emerging data to come through. This has started to go through the NICE process in that they say that the consultation will probably begin in September 2022. So let's hope that is the case, and that we can, if this is something we should be giving to patients, that this comes through quickly. And the final study that I'm going to mention is the ScanCell study, which is another combination study. These are slides from the company. So SCIB1 is a DNA vaccine used to treat melanoma. You inject it into the body. There's a photo on a subsequent slide. And there it's processed by cells and activates your immune cells. And then hopefully those immune cells go to any melanoma cells that you have in your body. This is the study that's being done at the present time, which will probably recruit over about 2 years and give up to 10 doses of this particular drug. We're combining it with nivolumab and ipilimumab, or just with pembrolizumab on its own, so that hopefully then pretty much every cancer patient with advanced melanoma will know whether this is something they should be having. These are the eligibility criteria as set out by them. So those that have got advanced melanoma, those that are going to have immunotherapy anyway, that have measurable disease so that we can see if we're helping, that are over 18 years old, and that haven't had treatment for advanced cancer before. So this is a first-line treatment. Again, you need your HLA typing to be checked and to be the right type in order to go into this. I'm just going to come back to that 18 years thing, actually, with one of my other bugbears. So the other trial that I mentioned had a cut-off of 12 years for being able to go in with the LAG-3. I think it's really important that we always think about these age limits, because, you know, you could have a 16-year-old, and we have seen 16-year-olds with advanced melanoma, and we'd want to be able to treat them with these treatments. So we should always think about why we've got that cut-off. And 12 does seem to be kind of the lower limit of what we think of as having adult physiology in our patients. These are the sites that are open for this particular study, so you can see some people have already got off the block, and others are coming soon. And again, north of the country, it would be good to have something up there. I quite often get asked about combining BRAF/MEK, which I've not really touched on simply because of the things that came through, but which some of you will have had with immunotherapy. So that you can awaken the force within and target treatment as well. We're big Star Wars fans in our house. Obi-Wan Kenobi is just great. We know that obviously these two strategies separately have good response rates. Preclinically, it looks like we should be able to put them together. There have been big studies now done looking at different immunotherapy BRAF/MEK inhibition combos, some of which my colleagues have been involved in. I think the jury is still out to some extent about whether we should be doing this, but the concern is that we gain a small amount, but that actually there's quite a lot of toxicity with these particular strategies. Those who went to ASCO, like Becky, may be able to tell us what the latest thoughts are on this side of things. I was here working, so in Sheffield working. But I think we'll keep revisiting this, but whether it's just how you carefully schedule your BRAF inhibitor in your immunotherapy, that's the way to do it. Those are also types of studies that are being done as well. I've managed to keep to time, and so to summarise, I know that was a lot, and really it was about giving you a flavour for it. These things change really quickly, and I know we'd mentioned previously, you don't have to go into a trial, but our standard of care treatments are here because of previous studies. You know, we're an evidence-based way of treating people. We don't yet have enough standard of care treatments, as that table near the beginning showed you. You know, I want to have many, many lines on that table. Well, actually, I prefer to have no melanoma and no lines and no job, but, you know, I don't think we're quite there yet. There are lots of trials ongoing. So when you asked me to do this, I thought, the last 2 years, do you know what we've been doing for the last 2 years? There's been this pandemic thing. But we have got studies there, some of which will never happen because, you know, the pandemic has meant that they no longer are relevant. Some of which we'll lose because we can't get the funding because there's not as much as we need at the moment. But some of which are there and ready, and what we need to do is make sure that we open them and put patients in. So, for example, Dante could close early if we don't get more patients into that. So, you know, do always feel that you can ask your clinical team about particular trial options. We're all very, very busy. Don't let the research bit get lost in that busyness. It is absolutely your right to ask about these things. So I am going to end there. Thank you very much for listening.